Hello, my name is Brenda Heileman. I'm here today to talk with you about healthy aging. This is Module 10 in your course, and I wanted to tell you a little bit about where I'm employed. I do work here at the university. I work at the Arnold School of Public Health, and I work at the Office for the Study of Aging. And you may or may not be familiar with this office, so I do want to spend a few minutes updating you and telling you a little bit about our work here. We basically have several responsibilities. We're, as I said, we're located at the Arnold School of Public Health. We're within the Department of Epidemiology and Biostatistics. Our office has been in existence for over 20 years. We primarily are involved in research efforts, program development, education and training, evaluation, consultation, and collaboration. And I'll break those down a little bit and explain to you what each of those mean. Our mission is to improve long-term care services and the delivery of those services for older adults, and to provide evidence-based information to policymakers, healthcare professionals, and the public. Some of our current initiatives include, along the areas of research, we were started 20 years ago for the sole purpose of maintaining the Alzheimer's Disease Registry. This is a registry that collects data on people within the state who have been diagnosed with Alzheimer's disease. There's a multiple data set that comes from various places. We receive data from hospital discharge records, nursing home records, we will start receiving from physician offices. We receive from the state health plan, and as I said, just a variety of other data sources that make this information very helpful and useful to policymakers as they plan for long-term care services in the state. We're able to look at the data per county, per diagnosis, specific, since there are various dementia diagnoses. So this is an area that, as I said, was really kind of the crux of what started our office initially. We have recently added a faculty member who will lead our research efforts, and so we're looking forward to having more activities along those research lines. Another activity that we're heavily involved in is education and training. We do have a contract with the Department of Health and Human Services, and we develop training modules for them for various long-term care programs. Right now we have a series of chronic disease management models that we're working on. We also have another training effort that has been around for over 10 years that is referred to as Dementia Dialogues. This effort we're preparing to put online. We do have trained volunteers across the state that deliver this training to caregivers and to family members as well as professionals. And you can find information about Dementia Dialogues on our website. And as I said, this effort is getting ready to go online. We're doing a development for that currently. In the area of program development, we are working currently with a grant from CMS, that's the Centers for Medicare and Medicaid Services. This grant is referred to as Home Care Plus. The goal of this grant is to provide home care to individuals, but also the plus means an additional layer of services that they're not receiving currently unless they're in this grant. And this plus service references those chronic disease management modules where families and recipients are trained in how to better manage their own chronic diseases with, excuse me, through the oversight of a nurse who's making home visits and helping them maintain the person in their home environment for as long as possible. And then finally, another initiative we're involved in is evaluation. This is a very important initiative for the Department of Health and Human Services, our contractor, in that this is how they determine the long-term care programs that they will develop, as well as the needed changes to those programs based on our evaluation. And when I say long-term care programs, I'm not only talking about nursing homes and assisted livings, I'm also talking about home care programs and other activities that are going on in the community. Today our objectives for this presentation will be to integrate the key concepts of aging within the role of public health, and I'm hoping I'll be able to do that through this presentation so you'll have an idea about how aging and public health can come together, and in fact there's also within the university a dual degree in public health and aging, so there are it's a very good connectiveness between the two programs, a lot of similarities and a lot of areas for expansion. We're also going to talk a little bit about some of the myths and misunderstandings about aging. We're going to look at public policy through an aging lens, and then we're going to finally talk about some future trends in aging policy and practice. Well, when we start talking about older adults, there's a very varying definition of what actually an older person is. Probably back, the first definition as it relates to aging was back to Bismarck, when 65 was the magic number. So anyone over 65 was considered older. Our Social Security and retirement and a lot of our public policies now are based on this 65 mile marker. On the other hand, AARP, the Association for Retired Persons, the American Association for Retired Persons, has dropped it back 15 years, and they consider older adult 50 and older. A lot of their work now is focused on prevention, so starting early at age 50 makes sense, and is one of the reasons that they look at that as the particular point of impacting on older adults. But actually, the literature, when you look at the literature, realizing that age has different levels, if you will, there's actually the young old, the middle old, and the oldest old. And the young old would be the early end of that, the 65 to 75. The middle old would be 75 to 90. And then the oldest old, which is one of our fastest growing populations now, would be people over the age of 90. We want to talk today and focus on healthy aging, and there are concepts that go into healthy aging. It's if you would just imagine the different things that impact whether a person, how they age and if they will be healthy. Certainly diet and exercise, key components in public health, are definitely there at the forefront of whether or not how someone ages. The genetic connection, whether or not the longevity of their family members, that's another impact with healthy aging. Their productive pursuits, if they're actively involved in things in their community, if they have a reason to get up in the morning, if they have things that are important to them, their social activity, staying connected with other people. So all of these things really do impact whether or not a person ages healthily. One other area that I did want to bring out as we were talking about the determinants of old age and what is really an old age, there is a cohort I would like for you to think about that you probably heard a great deal of information on, and that is the baby boomer group. And the easiest way to remember who is in that baby boom population is to think about the year 1946 and then the year 1964. And in essence, that's just a reversal of the 46 to 64. But during that period of time, it was following World War II, and the war was over, and the people were coming back from war. This was a time when the population numbers really, there were a lot of babies born. Basically, the baby boomer meant that there were a lot of babies born during this 20-year span. That group has now reached the magic age of 65. So with that large cohort, we can see that programs and services will really need to be enhanced and increased to be able to meet their needs as this group ages. And this is a group, too, that is really focusing on healthy aging for the first time, I do believe. There are a lot of efforts in prevention, and you see a lot of the myths dispelled because this group is very conscientious of growing old and trying to do as much as they can to prevent frailty and old age. Also want to talk a little bit about public health and what some of the things, how the relationship with public health and aging, what are some things there. First of all, there are dimensions of wellness. There's 8 actually. And if we start with environment, we're starting with where the person lives. There are certain places that are designated in the United States as well as around the world that are designated as healthy places to live. Places where there is a lot of attention to the environment and to the things that would impact someone's lifestyle there. Certainly, as we said earlier, the physical activity, staying active, exercising, doing the things that people enjoy makes a big, big difference and slows the aging process. Another activity or component, if you will, would be occupation. Of course, some people, when they do reach the retirement age, they're excited. They want to enter into that new phase of their life. But that sudden stop of having a career that is oftentimes more than 8 hours a day, the sudden stop in an occupation can be detrimental to a person's health. Recommendations now are to slow down and work part-time, but to not do that sudden stop, but to ease into retirement. And also for the whole, the benefit of still contributing to society and having a sense of that what you're doing matters and that you're needed, as well as being able to mentor younger people that are transitioning through their careers at the same time. Financial aspects is another dimension of wellness. When people retire, their income is usually cut at least by half. So changing their lifestyles to be able to accommodate less money can be difficult for some people. If they have not planned adequately for retirement, it can be a very stressful time where often they're not able to continue their lifestyle or even to make ends meet. They may be in a situation where they're having to make decisions about whether to buy medication or pay certain bills. So the financial stresses of aging can also carry a toll here. The intellectual dimension of wellness is also important. This is considered brain exercises. Continuing to utilize your brain to do activities, crossword puzzles, different things to keep your mind sharp is very important. The emotional component of wellness is also a consideration. As we all know, the older people get, the more losses that are experienced. In fact, there's a series of loss connected with getting older, loss of career, loss of independence sometimes, loss of ability to do things that have been done in the past, loss of family and loved ones. So the emotional aspects here are also critical in terms of being able to consider ways of dealing with those emotional losses and staying connected, which leads us to the next dimension, which is engagement or social connectedness. This is very important. A lot of times older people are by themselves or they're alone. Depression sometimes occurs when someone isn't staying engaged and having a social connectiveness there. Also the spirituality. This for people, for all ages of people, of course, is very important. a sense of connectiveness to a higher being. So those are components of wellness that definitely have a contribution or a relationship with public health. And so if you would, think of those as we go through the course today and how those relate. From a public policy standpoint, wanting to talk with you a little bit about aging through public policy, and to focus for a minute on the 8 centers that the CDC, the Centers for Disease Control, have designated as healthy aging research centers across the United States. As I said, there are 8. USC is one of those aging research centers. The other 7 include the University of Virginia, University of North Carolina at Chapel Hill, University of Illinois in Chicago, Texas A&M, University of Colorado, Denver, and then 2 representatives on the West Coast, the University of California at Berkeley and the University of Washington. These centers have been in existence since 2010 and do a variety of research and publication around the area of healthy aging. So if you're interested in finding out what's going on here at USC, you can go on the internet and check out and see what some of those activities are that are going on through our Healthy Aging Research Network here at USC. To spend a few minutes talking with you about career options in the field of aging. As I mentioned earlier, we do have such a growth of older consumers, and that will continue now for the next 20 years as that baby boomer generation has now started. They're turning 65, but there are lots of opportunities for people to work in the field of aging, a very rewarding field to work in. Certainly research, as I mentioned in the slide before, there is research going on right here on this campus that's very, very critical and important to the field of aging, and there's lots of opportunity there. Program evaluation. We talked about that earlier too. As new services and programs are coming about, we're constantly evaluating those and looking for best practices and looking to integrate those into the delivery system for older adults. And of course, to be able to evaluate programs, those programs need to be developed. So looking at the future trends, looking at the programs that are funded through Medicare, Medicaid, and other funding sources, and developing programs that are consistent with their requirements and are able and eligible to receive the funding necessary for that. Technology, certainly looking at the technological needs of older adults as it relates to remaining independent. There's work going on here at the campus too with robotics and older adults. Very, very interesting work there. One of your Blackboard slides or Blackboard presentations is about one of the professors here on campus, Dr. Janae Beer, who is working with robots and aging services. So that definitely, there's career opportunities if you have an interest in engineering as well as public health or social work. Education, certainly preparing the workforce for this group of individuals that are going to need these specialized services throughout their lifetime. So educating, particularly physicians, there's a very big shortage of geriatricians. So we need all levels of healthcare professionals trained in geriatrics. Care coordination is a service that is definitely popular right now with this group, and that is more or less providing services based on the person's needs. It's not a cookie cutter type service. It's really the service that results after a thorough biopsychosocial assessment to determine where the person is in terms of their service needs. So you'll hear more and more about care coordination and how that service comes into play with older adults. And then, of course, service delivery and just the wide variety of services that are available right now for older adults. And I will break those out into certain areas and talk about those a little bit later in the presentation. I want to spend a few minutes talking with you about some myths and misunderstandings of aging. And I think we all have seen these, particularly through marketing efforts and all, that a lot of times old age is not portrayed as very positive. And so there are things I think that we can do to kind of dispel some of those myths. And that would, of course, be focusing on those that group of people that are really healthy and that are really making an impact and staying active and creating their own spaces as they're growing older. I think we think about people slowing down, which is true. People may not be able to do what they did when they were in their 20s and 30s. But I think what the key importance here is that they can still do certain things. They can do things maybe at a slower pace, maybe not for as long, but the activities can remain intact. Loss of interest is also, I think, a misunderstanding. A lot of times just because someone has retired, then all of a sudden they do have more time for their special interests. So you do see people more active in terms of sports, particularly golf and tennis and some of the things that people enjoy doing. Another myth may be the inability to learn new things. Well, and as we know, this is certainly not true. There are people that are actively involved in learning new things every day. There are people that are going back and taking courses in college, so a lot of activity there. Pace slows down. It does slow somewhat, but as I said earlier, activities can be adapted so that they're able to continue to do the things that they enjoy. People set in their ways. Not necessarily true. I think the things that come along with aging requires people to constantly be able to adjust and adapt to those as they get older. Another myth is that people they lose their mobility or they're not able to get around as well as they were. Staying active will impact this in a very positive way, but there's also assistive devices that are available for people to use that will help with their mobility needs. Whether it's a cane, whether it's one of the rolling chairs where people are able to use these devices, and then if they need to sit, so it's kind of like not a wheelchair but not a walker, it's a combination of both. Another part of mobility, though, that we think about often too is their ability to drive, and I think we've all seen drivers that we feel are unsafe and that probably don't need to be driving. And to address this need now, occupational therapists are able to do an assessment for individuals to determine their responses and whether or not they're able, their eye-hand coordination and their utilization of their legs in terms of applying the gas and the brake, the timing on that. So that is a very helpful service now, as I said, the driving assessments. And this helps families and physicians being able to communicate to the older individual that it's time, to take the keys away and it's no longer safe for them to be driving. Another misunderstanding or myth about aging is the whole issue of companionship, social networking, and sexuality. And as we know, these are things that are important at all points in life, all ages, particularly with older the older population. So definitely we're seeing even widows, widowers in nursing facilities still being attracted to each other, still wanting relationships and to have that involvement. So that is definitely a myth that I think society thinks that older people have lost interest in these things, particularly sexuality. There has been research showing where there's been an increase in the prevalence of HIV with older partners, in the sense that they're not looking at prevention of disease, but prevention of pregnancy and not protecting. So there has been some issues with older adults and the need to practice safe sex practices. Integration, certainly intergenerational activities, not segregating older people with just people their own age. The importance of staying engaged in society and not just with their own age cohorts. Family life, maintaining their family relationships with their children, grandchildren, and great-grandchildren. Being part of the community, participating in activities that are going on in the community. As I said earlier, not being segregated into continuing care retirement communities or situations where they're not part of daily life, daily activity. And of course, being able to continue to make a contribution in some way or another, whether they're volunteering, whether they're helping another individual, helping an animal, but feeling like that they do make a difference and that they're making a contribution. A lot of people think that all older people reside in nursing facilities. And this is not true. There's probably around 5% of the older population that are actually in institutions. We do tend to focus on those because they're actually, I think, what everybody dreads is going to a facility. So that's one of the number one fears of older people as well as younger people. But this is not true. The fact that the residents, it is part of the continuum of care, and it is the last portion of the continuum of care. And so it's a very necessary part as well, because for these individuals, they do need assistance with a lot of their activities of daily living and maintaining their current status. Residents in nursing facilities, though, do have activities. They have planned activities, and they're usually pretty engaged as well, as long as their cognitive abilities are still with them. So I wanted to summarize a little bit. There was one of the Blackboard assignments that you were given was to look at the series Living Beyond 90. And just to kind of recap what we just said, and I think this series really puts it in perspective. It deals with a research project that was going on, and it tracked individuals. It was a longevity research project that looked at individuals over a series of time to see how active they maintained, and pretty much case stories on what happened to the individuals. I believe there were around 1,600 people in the study. But the secrets to healthy aging, certainly nutrition and diet, exercise, maintaining activity, the socialization. This study, there were a couple of things in the study that I believe were interesting, in that I don't know that they had been documented before, but the moderate use of alcohol was also brought out in the study, as well as maintaining an average weight. It was even saying that if the weight was too low, that it was not as productive as once thought. So an average weight, moderate alcohol use, of course, the mental exercise, and then the sexuality. All of these things are the secrets to healthy aging that the study continues to look at. We're going to talk a little bit now about some of the services for older adults. And as we mentioned earlier, categories of service include prevention, and then, if you will, on the continuum, you move around to community services, then social services, and then long-term care services. So the older adult is in the middle, and then around them, based on their specific needs, are an array of services that are categorized in these 4 areas. I'm going to start talking about preventive services. These are services that the older adult could access at any point in time, whether they're young old, middle old, or old. But certainly the exercise, the wellness, the recreation components. We've talked a little bit about employment, staying involved in some way. And if not employment, volunteerism, certainly the sense of being able to give back and making a difference and contributing is very critical. And so these are the 3 components of preventive services. The next service category that we'll talk about are community services. These services include information and referral, education, volunteer and intergenerational programs, income assistance programs, and senior centers. Information and referral is probably one of the key components to any of the service arrays, and that is, as we had mentioned earlier, looking at through an assessment what the individual's strengths and needs are, and then linking the individual to services that would help address their needs. Education also, lots of the senior centers, a lot of the activity or the recreational centers in counties provide education and provide socialization as well. They also provide volunteer efforts. Churches, of course, provide volunteer efforts in intergenerational programming. And then income assistance for individuals who do need to know about their benefits or know about different programs that they may be eligible for based on their income. Next, we'll talk about social supports. And this is, again, if you will, imagine that we're on a continuum. So social supports are services that are going to provide a little more assistance to the individual. Some of these services include nutrition, housing, transportation, mental health, health and wellness, and legal. Nutrition, certainly home-delivered meals is a good example of that service where people are either the meals are being delivered to them in their home, or they're going to a nutritional site and having food. Housing, Section 8 housing, housing assistance, also determining that they can no longer maintain a large home or the home that they have lived in for many years because of maybe needing now assistance with ramps or needing, the steps are harder to maneuver. So senior housing or other type of housing. Transportation, we mentioned once a person is no longer able to drive, then there are the issues of who will provide that supportive transportation. Mental health services, counseling are considered support services. And then legal services, we mentioned that a little bit too, in that certainly the need for wills, the need for planning, advance directives, the legal issues that a person would need to be thinking about too are considered support services. And then the final component of that service category would be the long-term care services. And this is made up of several components. Certainly we talked about case management, so having a case manager to help determine which of the long-term care services are appropriate for the person's need would be critical. There are also in-home services. A lot of people think that when someone reaches the point of frailty that nursing home or assisted living care is their only option, but not so these days. There are a lot of programs that offer in-home services. Another type of service that's offered has I guess an institutional feel or a congregate feel plus an in-home feel is known as respite or adult daycare service, and that is where the person may be in an adult daycare center during the day, but then be able to return to their home and be in their home in the evening and on the weekends sometime. So that's sort of a service in between being in a facility and being in the community or being at home. And then, of course, the nursing home or nursing facility, as they're referred to now, those are the services that make up the long-term care continuum. So breaking that down just a little bit more, think of the services as informal services and formal services. The informal services are the things that family and friends and community, neighbors, civic groups, churches, volunteers do for an individual. And those informal services are typically unpaid services. Formal services, on the other hand, are things that are delivered by social service agencies or medical care agencies. And those are definitely paid for. They're funded services and not volunteer services. We've talked about these here again. This shows us the long-term care services. As I mentioned, the care management, the in-home service. There in the middle is the adult daycare or the respite service and the nursing home service. Respite service is available so that people can get, respite means rest or a break. So this service is available where an individual can actually be admitted to an assisted living facility or a nursing home short term, usually a week, so that the caregiver or family member can take a break and maybe go on vacation or just take care of themselves for a little while so they can return to the caregiving responsibility. Okay. I want to talk a bit about, we talked about those formal and informal services. I want to talk a little bit about funding for the services. Prevention services, and I'm going to continue talking about prevention services, community services, social support, and long-term care as it relates to funding. Prevention services are typically paid for privately, private pay, or through the Older Americans Act. Community services can be paid for by private pay, Older Americans Act, or through grants and foundations. Social supports, the same, private pay, Older Americans Act. State and local governments sometimes fund social support services. The Veterans Administration also provides some social support services, as well as informal providers and volunteers. But then when we get to the long-term care services, we're looking at funding being broken out into local and federal. So there's some private pay. There's also long-term care insurance, which some individuals have that will help pay for their long-term care services at a certain level, either in the community or in a facility. Federally, there's the Older Americans Act that provides funding, and the Veterans Administration, and also Medicare and Medicaid. So as you can see, the funding, when we get into the funding part of all of this, it gets very complicated, and a lot of times this is where there's concern and confusion about what is covered by what funding source, and there again, that's when the care management service is very critical to individuals to help them through this maze of what is provided and what is paying for, what are the different things that are paid for. think about care settings in three ways. There's home care, which is home and community-based waiver services usually. Assisted living, which provides room and board and assistance with personal care, and not a lot of medical care or medical monitoring. And then the institutional care, which is nursing facilities, and it's providing skilled medical services. And these three, people can go beyond these three. They may go to a nursing facility to receive rehab after a broken hip and then return back to the community, to their home. So they're not, I guess that's another myth, is that people would go to a nursing home and stay there forever. Not so these days. More and more people are going for rehab and then are coming back out. And then, of course, an example of the home-delivered meals. This is one of the, an example of a social support service. Case managers coordinating services and trying to find the most appropriate resource to link a person to services that they need. I want to talk a minute about Medicaid, a Medicaid service called Home and Community-Based Waivers. You may have heard of this service, but it is, right now there are more people in South Carolina receiving home care services through this program than there are people that are residing in nursing homes, which is very encouraging. There's over 14,000 people in the home care program right now and around 11,000 Medicaid-funded nursing home beds. So that is that's showing a trend that more and more people are staying at home longer. The Medicaid waivers, they're an alternative to institutional care. To be eligible for a waiver, a person must meet the same medical criteria as that is required for nursing home placement. These waivers are part of a program where the state has to apply for these waivers every 5 years, and they're approved by the Center for Medicare and Medicaid Services. They also have to be, there's a cost-effectiveness component to this, so they have to be, have to show that they're not spending any more money having someone remain at home than they would in the nursing home. In fact, they're looking to show a savings by having the person at home. They have to meet, as I said earlier, a medical criteria, which is the nursing home level of care. And they also have to be financially eligible, which means they would be eligible for Medicaid in the community. And the Medicaid criteria looks at their monthly income, and then it looks at their resources of the things that they own, their property, and what have you. The case manager works with the families and the individual to decide to decide what their service needs are, and then a plan of care is developed that will address what those needs, what the service needs are. The providers are enrolled as Medicaid providers, and the client and the family have freedom of choice, and they're provided with a list of the Medicaid providers, and they can choose the provider that they would like coming into their home to deliver their services. Individuals in this program must be 18 years or older, 18 years of age or older, and as I said, they have to meet the nursing home level of care, be Medicaid eligible, and we have already mentioned that there's more people in this program now than there are actually in institutions or facilities around the state. An example of some of the services are, of course, case management's the primary coordinating service, personal care, which provides assistance with activities of daily living. We talked about adult day health care. Respite is also provided in this as one of the community services. Incontinence supplies, Meals on Wheels, environmental modifications such as the building of wheelchair ramps or adding grab bars in bathrooms, and etc. Nutritional supplements, emergency medical response system, which is referred to as PERS. This is the button you would press it, I've fallen and I can't get up system. different kind of medical equipment, companionship. So all of these services are things that are provided in a person's home to help them maintain and stay in the home. I want to talk a little bit about facilities, though. We'll talk a little bit about assisted living and about nursing facilities. But wanting to be sure that we outline the differences, because a lot of people think that they're the same thing, and they're basically not. The assisted living facilities are the newer. A lot of times they're the ones that you're seeing that are the newer facilities that have been built. And they basically are private pay. There aren't any federal funds that go toward payment of assisted living facilities. There is a state-funded program known as optional state supplementation that would assist in payment to facilities. But most of what we're seeing now, the newer ones, are all private pay. Their admission requirement is that the person would need some form of personal assistance, but there's not the strict criteria about meeting a certain level of care. In some cases, the staffing is non-medical. In some cases, facilities may have a nurse on staff, but it's not part of a DHEC regulation that a nurse be at an assisted living facility. Their quality assurance is a minimal state requirement. There's no federal oversight of assisted living facilities. Now, nursing homes, on the other hand, have been around for a long time, and they are federally funded and federally monitored. Their funding sources for nursing homes are Medicare, Medicaid, Veteran Administration, VA, or private pay. There are admission requirements for Medicare and Medicaid. They have to meet a level of care, a medical level of care. There has to be medical staff on duty. There has to always be nurses, personal care, or certified nursing assistants. The quality assurance of these facilities is mandated by the Center for Medicare and Medicaid Services, and they're very strictly regulated both by state and federal regulations and certifications and reviews. So a little bit about what a nursing home, some more services that a nursing home provides is they provide room and board, meals, recreational activities, and assistance with activities of daily living. As I mentioned, they have trained professional staff on duty, social service staff, RNs, LPNs, CNAs, physical therapists, occupational therapists, speech language pathologists, and a medical director. They also can provide restorative and rehab services short term. They can provide respite, as we mentioned earlier. Residents that have been called different names, you've probably heard them referred to as patients, elders, but with the regulations that came out in 1987, known as OBRA 87, Omnibus Budget Reconciliation Act, the official name at that point for it changed from patients to residents, since the facility was viewed as their home and they were residents within that facility and not patients, as patients denoted a medical model. Nationally, there's over 17,000 nursing homes. In South Carolina, we have about 200. And most of those 200 are certified as Medicare and Medicaid providers, and 150 of the 200 participate in the Medicaid program. So from a policy perspective, before OBRA 87, the facilities were not regulated as well as it relates to residents' rights and quality of care. The facilities at that point, in some cases, were referred to as county homes, or they were poor homes, retired nursing homes, county homes, what have you. In 1950, though, the Social Security Act allowed people in institutions to start receiving benefits. And then, of course, the real impetus was in 1965, where Medicare and Medicaid started funding long-term care services. This Nursing Home Reform Act, over 87, brought about some really key components, such as the requirement for nurse aid training and testing, the PASSAR to make sure that people, that's pre-admission screening and annual resident review to make sure people didn't have mental health issues that needed active treatment. It set up a minimum data set for assessment so that nationally the information collected is consistent. And of course, the Residents' Bill of Rights was enacted there, and also sanctions for poor performing facilities such as denial of payment for new admissions, terminations of the Medicaid contract, Medicare contract, as well as sanctions. Here in South Carolina, the regulatory authority is the Department of Health and Environmental Control, and they license facilities as well as do the annual surveys. They look at, when they go into a nursing facility, they have done a stratified sample so that they're able to know which residents require the most care needs, and those are usually the residents that they monitor their charts and interview and look and follow up on their level of care to make sure that it's appropriate. So there's a couple of pros and cons to placement. Like I said, people fear going to nursing homes, and a lot of times people just, that's the worst fear that they have. But the nursing homes or nursing facilities can be the right level of care for some people, particularly after a caregiver has reached the point to where they can no longer provide the care and they're burned out and worn out. So a con or a pro for placement would be to reduce that caregiver stress. 70% of the residents are positive about, they have positive attitudes about their placement. And in some cases, there's an improvement in the residents' health and mental health and physical health because they're socializing with other people and there are activities going on. The caregivers are rotating off of shifts. It's not one person trying to do 24-hour care. They meet new people. The aspect of loneliness sometimes is alleviated. I guess one of the cons, though, is that their income, goes toward if they're on Medicaid, their income, their recurring income is part of the payment. And in some cases, there are high levels of depression in nursing facilities. So it's kind of like weighing the pros and the cons. But as I mentioned earlier, a lot of times when families have reached the end of their rope, it is a comfort that the nursing homes are available to give them some relief for their loved one and their care needs. In South Carolina, just to take a look at how payment is broken out, as you can see, 65% of the pay source hits here is Medicaid, large portion there. And then we have the number of Medicare and private pay being neck and neck at 18 and 17%. One of the myths, too, around aging is that Medicare is going to pay for everything. And as you can see from this slide, Medicare will pay initially, sometimes up to 100 days, but certainly is not the major payer for nursing home care. And in talking a little bit about Medicare and Medicaid, I just wanted to try to explain a few differences to you because, as I said earlier, people confuse the term nursing facility or nursing home and assisted living, but they also confuse the terms Medicare and Medicaid. They're both federal programs, but the main difference between the Medicare program is that it's paid through employment contributions. So people that have worked are paying into Medicare. The eligibility is usually based on age, which is 65, or disability. There's certain disabilities, such as end-stage renal disease, as one example that would prompt someone that's not 65 to be eligible. Medicare has various coverage levels, such as Part A, Part B, Part C, Part D. You're probably familiar with some of these, and those different parts cover different components of medical needs. But the coverage is minimal. particularly for nursing facility services and for home health services. Medicaid, on the other hand, is based on income, and it's for people with lower incomes. To be eligible, people are either aged over 65, blind, or disabled. And there's various categories of eligibility. There are categories for pregnant women and children. There are categories for people with certain diseases. So Medicaid is pretty complicated as well. But Medicaid, as we've seen on the slide previously, does cover the bulk of long-term care in most situations, both home care and institutional care. We're going to talk a little bit about the Affordable Care Act, and as it relates, we've been talking about policies, we've been talking about Medicare and Medicaid. Now we're going to move into the Affordable Care Act, because this act is moving states forward, their long-term care systems and supports, and there's different ways that this act allows states to do certain things that would promote their long-term care services. In South Carolina, there is an AARP scorecard that was recently released that ranks states. Unfortunately, South Carolina didn't rank very high with these components, and those components, we ranked 38 as a matter of fact. But those components are support for family caregivers. We ranked 44th in that area. Ease of access and affordability, we ranked 15th, which is, that was our highest score. Choice of setting and providers, we ranked 35th. And the quality of care in life, we ranked 29th. If you're interested in seeing more about these rankings, it is on the AARP website, and it's called the scorecard, and you'll be able to compare South Carolina with other states. The goals of this card, though, deal with trying to improve performance, trying to increase the number of people receiving home care services, so that there's more people receiving home care than being in an institution, to decrease hospitalizations, unnecessary hospitalizations, to transition people back into the community from nursing homes, and to increase income limits for Medicaid so that more people are eligible financially for the Medicaid program. So those are the obtainable goals that this project through AARP is looking at, and it's an ongoing study where they'll be looking to see if states are making progress in these areas. I want to talk about Healthy Connection Prime. This is a new initiative with the Department of Health and Human Services. Healthy Connections is the name now of the Medicaid program in South Carolina. Instead of Medicaid, we're now using the term Healthy Connections. Prime is the program that I want to talk with you about briefly. What we're trying to do, as I said, is look at ways to blend funding streams through the Prime program. This is a new option for individuals that are 65 or older with Medicare and Medicaid. So if you hear the term dual eligible, that means they have both Medicaid and Medicare, and they would be eligible for the this new program, Prime. It's going to try to fully integrate all of the healthcare services through a managed care entity that's known as an integrated care organization, a CICO, Coordinated and Integrated Care Organization. So there's a triple aim here. It's to provide better care through a person-centered model, better value by focusing on quality and not quantity, and better health care for the older population. This program is part of a Medicare or CMS grant, and it has different levels of a timetable as to when different things will happen in the state. It's right at the cusp of the Medicare and Medicaid programs. Next year will be 50 years old. As I said, those programs started in 1965, so in 2015, those programs will have been around for 50 years. So this is an effort to take those two programs and blend them and try to coordinate the care, try to coordinate the services, and make it less complicated for the beneficiaries. So we'll look at combining Medicare Part A, which is hospital services, Medicare Part B, which is physician and other outpatient services, and then to expand the Medicaid program to be able to fill in the gaps and to make sure that we have a fully integrated program with the Medicare and Medicaid services. Some of the benefits of this program will be there'll only be one card. Right now there are 3 cards. There's a Medicare card, a Medicaid card, and a prescription drug card. So this new program will result in only one ID card. Right now there's 3 sets of eligibility requirements and benefits. This new program will have 1 set of benefits. They'll all be combined and coordinated. Hopefully the communication will be enhanced. There'll be more case coordination through a physician, a medical home. The providers will interact and know each other. It'll be more person-centered with a multidisciplinary team approach. There will be a palliative care benefit and some of the other enhancements such as the individualized care plan, the medication reconciliation, and hopefully all of this, as I said, will bring about more coordinated care. It'll provide a rate structure and a quality incentives for the providers too. So if they're meeting their care goals, then there will be incentives. They'll be able to provide more care to individuals. This is, as I said, it's a CMS-funded state demonstration project. There's a lot of activity throughout the country. South Carolina is one of the states that's moving farther along with this program. The timetable consists of a rollout January the 1st through March the 30th. In 2015, this is an opt-in enrollment. Then a passive enrollment will begin on April 1st. And the state will come in 3 waves geographically. The upstate will be the first wave. The southern to Midlands will be in the low country will be the second, and then the waiver programs will be the 3rd wave. The Medicaid services will include behavioral health, the home and community-based waiver services, and the nursing home services. The Medicare services will include primary and acute care, drug coverage, and the skilled nursing benefit. As I said, we're looking at the birthday celebration of Medicare and Medicaid, 50 years old. Here are the differences without the integrated care and with the integrated care that I've just reviewed. Here are the states, the demonstration states, and the color codes will show you where different states are. Here we are, South Carolina. And I think this slide helps depict that this is a person-centered approach. We're trying to, there will be like a toll-free number. People will have an individualized care plan. Disease management, disease self-management and coaching will be encouraged. Medication review. So all of the disciplines around the circle will be focusing the person-centeredness here of the service. So we look at retirement, we look at the, it can either be, if we can prepare for retirement by saving and planning for it, because as we mentioned earlier, the income does decrease at the point of retirement. So we want to plan accordingly. We want to try to maintain a healthy lifestyle as long as we can. Those are some of the things that we can do. But the reality is people are living longer. Medicaid will continue to be the nation's major source of financing for long-term care services in both institutional and community settings. And over 10 million Americans will need long-term care services and support to assist their activities of daily living in the future. So, as I said earlier, preparation is key here. What I would like to encourage you to do is to go on Blackboard to the discussion question and have a discussion after looking at the other things that we have posted on Blackboard, but discuss from a public health perspective. How do you see trends in aging impact the future of health care as well as for you and for your career? And as you look at those Blackboard posts too, we've got several things on there that I've referenced today in this presentation, as well as some things that hopefully will help you to understand the importance of healthy aging and the impact that it will have on society as well as you personally. Thank you for your attention today.